Good afternoon, everybody, and welcome to the conference. Today, and thank you for that great introduction. Today, we're going to talk about care patients with mental health issues. We had a quality improvement project. Next slide. So, um, I want to reach out to Dr. Sean Zembos, our clinical nurse specialist, Tally Montesi, one of our staff nurses, and Dr. Jason Roth, and Dr. Lynn Pachelski Goldstein. These were incredible practice providers helping with the project in improvement. Again, there's no financial disclosures, nothing to disclose. And again, this is for our patients and community. Next slide. So again, emergency behavioral health care, to cure sometimes, to help often, and to confront always, hotel do. Next slide. So we know a little bit of background here is behavioral health or mental health concerns have increased dramatically over the past decade. And in 2018, there was an estimated of 130 million visits to the emergency department in the United States, and about 18% were behavioral health visits. Next slide. And according to the Institute of Healthcare for Improvement, the IHI, in 2018, they identified that many of our emergency departments are not equipped to provide any level or advanced care facing our behavioral health crisis. And truly, we have been in a crisis since the pandemic. And again, we know that patients will wait for their psychiatrist or social worker or advanced care or other specialized health care to receive the next level of treatment. Next slide. Next slide, please. Thank you. So we had a process improvement project. Again, this presentation is going to examine a process improvement within an emergency department in the United States and how we could provide evidence-based tools and care and improve systems. Next slide, please. So again, identifying our clinical concerns. Like some emergency departments, we're located in the western part of the United States, specifically Colorado. We identified that we lacked education and regarding management and optimal care for our behavioral health disorder patients. We identified that we had many patient elopements. We had a poor infrastructure and an inability to provide safe care. Next slide. So again, identifying our clinical concerns. These were shortcomings through a gap analysis. In 2018, we established a team of clinicians and clinical leaders and implement the project. Before this process improvement, the department experienced two horrific workplace violence incidents. Two of our associates were just beaten and just experienced a lot of physical and mental trauma from some patients. With that, we identified that our physical layout and our boarding process of our behavioral health patients was just terrible. Next slide. So getting the team involved, this is important for shared governance, for empowerment, and providing exemplary care. So with our gap analysis, we implemented teams who were made up of frontline staff. So again, the people that do the work, they were nurses, they were ER technicians. We got our quality department involved, risk management, pastoral care, our facilities, the people that help run the facility, security officers, our emergency department, and hospital executive sponsorship. So at the end of the day, it's our hospital executives that bless us and provide us fiduciary and financial support. Next slide. So we know suicidality and Joint Commission. So in 2012, the Joint Commission reported that half of the sentinel events all occurred in the emergency department. So we have an issue there. And in 2018, the Joint Commission also wanted to address suicide prevention. So what are we going to do? What are we going to do to prevent bad things from happening in the emergency department? And again, patients with behavioral health disorders are an increased risk for self-harm. They require dedicated care, especially in the emergency department. Next slide. And so in general, our staff are initiated, provide initial assessment and stabilization. We know how to treat trauma patients, stroke patients, cardiac patients, and we're provided brief episodic care, and it's really not longitudinal behavioral health care that we provide in the emergency department. Again, we know that we don't have clinical staffing models that provide the one-on-one care for acuity of patients. As an administrator, we know we're under the gun for productivity and staffing models. And so just to provide that one-on-one dedicated care, we just can't meet the needs of our patients. And again, our gaps resulted in delays in recognition and assessment and treatment for our care. Next slide, please. So caring for behavioral health disorder requires various resources and allied health professionals, not just nurses. We need de-escalation training, how to communicate and talk to a patient. We need infrastructure or the physical layout of our department and ligature risk reduction. And again, we know that the Joint Commission identified and recognition risk assessment and various policies. So if you're looking for the magic wand, there's no single set of solutions for patients with behavioral health disorders to improve boarding, because again, we have various differences, not only in the state of Colorado, but throughout the United States and the world. Next slide. So what are we going to do? Well, we're going to hit the books and we're going to do a literature review and evaluate our process. So we did an extensive literature review from 2015 to 2020 of this, and we evaluated our organizational gaps, and we identified several areas of concern. Number one, our organization didn't even use a valid suicide risk assessment tool. So how does that happen? And we also identified that our intake process and securing belongings and patient and safe gowns was inadequate. Our gowns had ligature risks. Next slide. Thank you. So again, there were many significant ligature risk areas. We identified that staff wasn't trained in de-escalation techniques or communication. Again, we had many policies outdated. Next slide. So our facility. So our healthcare system is comprised of a large multi-state hospital facility in Denver, Colorado. We have one electronic healthcare platform, specifically that's Epic. Our hospital is a 224-bed medical center in the Denver metropolitan area. It's a 48-bed emergency department that has 6 dedicated behavioral health disorder rooms. And then each hospital in the health system and the respective departments support and maintain their own policies. And there's no system-wide ED policies addressing patients with behavioral health disorders. So again, there's variability even within our health system. Next slide. So again, our hospital, ironically, doesn't have inpatient or outpatient behavioral health services, and we have very limited behavioral health resources. Ironically, out of 50 states, Colorado ranks 47th in behavioral health services. We are one of the worst in the United States. Next slide. Thank you. So again, patients with behavioral health disorders, they come to the emergency department. Their common reason for the emergency department visit, a fifth of all patients have these disorders and complaints. And again, the emergency department nurse and staff plays a huge role for this patient population. During our process improvement, staff expressed frustration regarding the physical layout, all the ligature risks we have, the amount of patients that eloped, and the need for de-escalation training, and the lack of consistent documentation. Next slide. So during how wild is this? During one of our Joint Commission visits, one of the hospitals was identified not having an adequate suicide risk assessment tool. It wasn't my hospital, but as a one electronic health record, we use the same tool. So It's just a matter of time that Joint Commission was going to come to our hospital. So the great news is, as a health system, 17 hospitals, we met as a multidisciplinary team. We had ED leadership, our quality department, risk management, and our health systems information technology, the IT division. And the experts, the clinical nurse specialists, the medical directors, the psychiatrists, identified and agreed that the Columbia Suicide Severity Scale will be the tool, risk assessment tool that we question and evaluate our patients with. So within a week, we implemented the Columbia Suicide Risk Assessment tool within our electronic health record. So the great news is 17 hospitals, we didn't argue or agree or disagree which tool we used. We used the Columbia Suicide, and we implemented it, and then we trained and educated. So the next time Joint Commission comes to one of the hospitals in the health system, we at least had a valid and reliable tool. Next slide, please. So we know that Columbia Suicide Severity Rating Scale is the most widely used suicide scale. What's great about it, it has strong psychometric properties. Again, the alpha reliability is ranging from 0.84 to 0.9. And again, here's an example of the questions, the mild, moderate, severe ratings and rankings of the patient. Next slide, please. So our physical layout. Again, with our gap analysis, we identified many ligature risk opportunities, and we needed to improve the area. This was a 6-bed emergency health room. We had stretchers on them with many hold points. There were items on the wall and doors that needed to be covered up. And so what we had to do is we had to remove our stretchers and place new floor wall mounted beds and no hold points. We even had gloves, small, medium, and large boxes in each room. And again, that provided ligature risk. So remove that. Next slide, please. So our physical layout, the great news was each room, the 6 rooms, we outfitted with a clock. So just imagine being in these rooms for hours and maybe even days on end and just not keeping track of time. There's no direct sunlight. So at least having a clock on the wall was great. We also had wall-mounted shatter-resistant television for patient use. Again, patients, whether they're there for hours or overnight or days, they need some kind of interaction. So providing them a TV was a great opportunity for these patients. And again, our floor-mounted beds. These beds cannot be picked up, thrown, kicked, and so there were no hold points on them either. So this was great. So if one of our employees can't be tripped or pushed into a stretcher, it's mounted on the ground, and our patients don't have the ability to move it around. Next slide. So each patient door had to have a piano hinge and a ligature-resistant doorknob. You'll notice on the bottom picture, these doorknobs, we took dental floss, and we can't even get dental floss around these. So again, we went and ensured that patient safety is incredibly high. And so there's nothing that's going to provide ligature opportunities for our patients. Again, each room was outfitted with security cameras to include infrared cameras and low level. So in years past, we had a green ambient light in the room. So the lights were never fully off. And I don't know about you, but I can't sleep without the lights off. And many of our behavioral patients who we've interviewed to be a part of the process improvement, they've said it would be great to turn the light off so they can get some shut eye while they're waiting for a disposition or the psychiatrist or medical care. And so we had a switch that can turn the light on or off. And when the light is off, the great news is we still have the one-on-one. We can still see the patient in low-level lighting. Next slide, please. And our bathrooms and showers. So we need to provide basic hygiene needs for ED boarding patients. We had a bathroom and a shower that were inadequate, and we had a floor that leaked out into the common area. And so we installed new sinks, toilets, dispensers, and we are our facilities team, our plumbers, our electricians, our carpenters, our journeymen find what were the best sinks and toilets and shower knobs and mirrors, and we had to break concrete on the ground to have proper drainage. So again, falls are, patients are always at risk for falls, so we improved that for them. Next slide, please. We also installed specific bathroom doors with piano hinges and breakaway points. So again, patient privacy is important, but we also wanted to see if there's anything going behind the door. So anything that they want to try to harm themselves or remove. It was kind of like a barn door that swings open and closed, but again, piano hinges and appropriate safe doors for entrance and exit. Next slide, please. So there was a common area in the nursing station. We've improved the lighting and flooring. We added shattered resistant glass and ergonomic seating for staff. Again, this is a staff satisfier. We had 2 staff members harm with the layout of the common area, and so we want our staff to always, number one priority, be safe, and so we improved that. We also had badge operated locking mechanisms and staff panic buttons. So if there's ever an event that gets out of hand or we need additional resources or safety, they have the ability to do that, and locking in and out so a patient cannot elope. That was another strategy. Next slide, please. So again, you heard earlier within our gap analysis, we would lose patient belongings. And so during our intake, patients would be placed in and take their clothing and personal belongings. We'd properly label it and put it in a bag and lock it in their dedicated locker until a final disposition was made. So whether they were being admitted or transferred or discharged home, we did not lose their belongings and clothing. The other great thing with our electronic health record through Epic is it does provide a detailed account of equipment, supplies, belongings, etc. So we had a better way of documenting patients' belongings. Again, that included a detailed inventory and tracking, and we decreased patient complaints. Next slide, please. So ligature-resistant patient gowns. So again, patients were dressed in green, ligature-safe, disposable paper gowns under the supervision of the staff. So whenever there was a female patient, we'd get female staff. Again, we have gender considerations and cultural considerations. Those are really important for our patient population and our staff. Our health system regarded green as a universal code for safety, and again, these gowns were provided for situational awareness and clinical staff should a patient want to elope or wander. So this is another good visual for our staff. Next slide, please. And again, de-escalation training. Patients with behavioral health disorders can escalate and require interventions. So our facility had a wide spectrum of experience. The majority of the staff didn't have proper education or training to de-escalate. And so we identified and chose the Crisis Prevention Institute, CPI education. It's a nonviolent crisis intervention to better train our staff and enlist and educate other hospital staff. For instance, patients have challenges in the ICU or med surg, so it's not just about the emergency department. Although 50% of the Sentinel events come from there, we partnered with our inpatient nursing units as well to provide them the proper communication and de-escalation tactics and health for the patients. Next slide, please. So our behavioral health technician. So we identified the need for a behavioral health technician in the emergency department. Fortunately, our health system already had one of these dedicated in their inpatient outpatient. So out of the 17 hospitals, one of our hospitals had inpatient outpatient site, and including that they had a behavioral health technician. And so we adopted that position within the emergency department. And again, within 6 months, we implemented the new rule. They enhanced the care of the patients with behavioral health disorders. Again, their training included de-escalation process, again, sitter needs, documentation, and overall support. Next slide, please. So our behavioral health technician, again, the new rule prevented elopements, violent escalations. It helped document patient belongings, added overall value to the multidisciplinary approach. It improved communication with the patient and the healthcare team. Next slide, please. So our policies. Again, 17 hospitals, but our specific one, we had met with our multidisciplinary team. Again, our clinical nurse specialists, our ED staff, our ED leadership, our physicians. We reviewed and revised our outdated behavioral health policies and procedures. And again, these were shared with the whole health system. And the whole health system said, instead of having variability, why don't we adopt one? We know the facilities might be a little bit different, but the process and the guidelines should be the same. And so we did that within our safety software system and policy system. And then we had an automated timeline and trigger. So every 2 years, these policies would pop up to the respective owner, and we'd have to review them as a system. So now we don't have outdated policies and procedures. Next slide. So again, we mentioned the Plan Do Act. You know, we have to do our process improvement evaluation. So let's evaluate the process and what became of it. So a year after implementing the process improvement, we evaluated the effectiveness of decreasing patient elopements, workplace violence incidents, and lost patient belongings using our continuous quality improvement. Again, operational challenges were tracked and resolved using our PDSA methods. Again, data we collected was from our health electronic database and our quality reporting system. Next slide, please. So here's the results, and we're just so proud and excited with our results. So what did we learn? So our patient elopements decreased from 0.58% to 0.02%. It's really non-existent. Our workplace violence decreased by 93% after implementation of our CPI de-escalation. So just by properly communicating, situational awareness, safety, we have a safer place. And this was a low-hanging fruit. And then our incidents of lost patient belongings were basically eliminated. So now that we have a process to store their clothing and belongings and to properly document it with the electronic medical record, we now don't lose patient belongings. Next slide, please. So again, emergency nurses must address education, guidelines, policies, procedures. We're influential in improving the infrastructure and knowledge and continue to evaluate process improvements to improve quality of life for care of our patients that we treat. And again, we need to have the proper education and knowledge and provide our patients with compassionate and empathetic quality care. Next slide, please. What questions do you have? This was an incredible process improvement in one facility that we really improved the overall health and wellness of our patients and improved the safety of our staff. Thank you.